Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Now, this is, I was taking previous lecture on subcutaneous fungal infections. Session 1 has been described with you with the spore and the chromoblastomycosis, basically. And the third infection, which is very, it's at one time it's very important, that is MADURA foot. At one time when I was a student, there was a specimen which is there in the pathological lab. And in examination, they actually picked this specimen, examiners picked this specimen on the table for the candidates. It means that this disease is definitely present in our country. And it was imported food, which was shown here in the specimen in the pathological museum. Although I have seen also 2 cases of MADURA foot in my life. Although because this is not my subject, actually it is a surgeon, surgical and right, specialty, but I have seen 2 cases of the MADURA foot. I am Professor S.L. Yedar, and I am an honorary global professor of medicine without any name or fame or economics. Although this channel is definitely free for all, nobody is actually interested in watching this type of lectures, and the subscription is very small. No problem. I will deliver what I know about it, because the medicine actually, the main subject of the practicing the medicine actually is practicing medicine, that is called. And if you know the basics and the background of the internal medicine, you can survive, otherwise you cannot survive. Whatever specialty you will choose, if you are weak in the internal medicine, you will be weak for life in your specialty. This is my message. So if you have a time, please watch these videos. That is actually I want. Now, this MADURA foot is caused by the 2 organisms actually. One organism are from the is bacteria, and it is that weakly positive, gram-positive bacteria, which is known as Actinomyces israeli or Actinomyces other families. Another one are the parasites. No parasites. It cause the MADURA foot. They are fungi. Because fungi behave like a parasite, that's all right, but they are fungi. A fungus is causing this MADURA foot. I have seen these cases. This is cultured and proved to be a fungal infection, superadded by a secondary infection. Now, Eumycetomas is the broad terminology, which means that any swelling or any tumor-like mass caused by the specific agent, which are more than one in case of the fungi are concerned. Fungals is concerned. It is a MADURA foot in the common name, MADURA foot, and is a persistent fungal infection of the skin and the tissues just under the skin, affecting the most commonly the feet, although it can occur in the hands and other body parts, depending upon which type of work you are doing. It starts as a painless wet nodule, first of all. Nodule means it is above the skin, it is more than 2 centimeters, and you can palpate it, and the firm swelling, a swell nodule, which may be present for years. It is started, but it will, the growth is very slow. For many years, then ulceration develops, swelling, and a grainy discharge. Grainy discharge, and they will be associated with the weeping from the sinuses and fistulas, followed by a bone deformity. This is the correct explanation of the Eumycetomas, whether it is due to the bacteria or it is due to the fungus. This is seen here. A lot of, here sinuses or blind tracts are there. It is there, and here it is charcoal type of a picture. All destruction occurs, and there is nodules, all ulcerations, some sinuses are visible. And this type of the food was shown in the specimen at one time in the pathology, favorite specimen of the examiners. Etiology, there are several fungi can cause Eumycetomas or MADURA foods, including the Madurella mycetomatis, Madurella egregia, Leptosphaeria, and Seniculensis, and Carvelia alunata, and Scaloporium epiosperm, and the new Testudina rosatae, although this is a nauseating type of the terminology. I'm using only one organism you can remember, Madurella mycetoma. And other one are the Acromonium and the Fusiferum species. If you can remember, that's all right. If you don't remember, no problem. Diagnosis is by biopsy, visualizing the fungi under the microscope, and culture. Medical imaging may reveal the extent of the bone involvement. Assessment will be there. And other tests include the ELISA. It may be diagnosed by immunodiffusion, and it may be done by the DNA barcoding. These some tests are available in Pakistan. The cheapest one is the culture one. You can culture it under the microscope. You can see the specimen over the characteristic feature. Now this is a very important, slide, that is mycetoma can be caused by the bacteria, Actinomycetoma that is called, if it is done by this. If it is caused by the Eumycetoma, it is fungi, it is called Eumycetomas, fungal origin, bacterial origin, Actinomycetoma, which will be discussed later on. Now, Eumycetoma, if you say that this is a MADURA food which is caused by the fungi, distinct from the mycetoma caused by the bacteria from the phylum Actinomycetes, that is, at one time it was included purely in the fungi. Now it is separated, Actinomycetes. Both have similar clinical features. All those features are similar. They behave like a similar pathological condition. The most common fungi causing the white discharge are the Pseudomonas lichria, now Pseudomonas body. Other causative organisms of non-black grain Eumycetomas include the Acromonium and Fusiferum species. Black discharge, as you see, the species are Madurella mycetoma, I already said, but Paranoachiata and Exophilia, Leptosphaeria, and Corbularia. No, don't remember it. Only this should be known to you, or otherwise this will be known to you, rather than this. The most common species are the Madurella mycetoma and Tematosphaeria grigia, previously called the Madurella grigia. Geographical distribution, the infection occurs generally in the tropics, and the endemic in the sub-Saharan Africa, especially in Sudan, India. They are mentioning India, not Pakistan, but it is included in this, our country, because no research and no data was available, which I can present to you. It was definitely, the data was not accepted by WHO, which was presented 1 decade before. The parts of the South America and Mexico, these all parts they are shown here. They are all the grassy lands, and there are a lot of cultivation are practicing in these areas. Few cases have been reported across the North Africa also, although it is not common there. Mycetoma is probably low endemic. It is also present but low endemicity in Egypt, with predilection of the Eumycetoma more fungal. In 2016, the WHO recognized Eumycetoma as a neglected tropical disease. Because you can't consider it, because you don't remember it. How can you, differentially diagnose a food which has got a lot of, a blackening is there, or a sinus formation is there, or it seems to be a gangrene of the food, etc. If you don't know the name of this disease, you can't, differentially diagnose. That is why it is neglected tropical disease. Nobody wants to learn. That's all. Pathogenesis. One thing important is for the students who are appearing in any examination, like MRCP or the step 1 or 2, etc., or FCPS or MD examination, etc. Just like this, they are fond of in the theory is concerned, of practicing the MCQs, BCQs, MCQs, BCQs, MCQs, BCQs. and then they appear in the clinical examination, and some lucky person have cleared out. But as a clinician is concerned, they are not, they will be. I will definitely predict that they should be very less chances of the good physician from this type of work which you have done previously. But whatever it is achieved should be achieved. It is 100% achievement. So there is nothing in sorry is I don't know. This is not the sentence. You can't say to the examiner. The pathogenesis of the disease is acquired by the entry of the fungal spores from the soil through a breach in the skin produced by the Manatoma like thorn prick. And doing in the grassy land, there are a lot of thorns are there and other things and pebbles and there are sharp, type of stones are there. They can cause Manatoma because of the barefoot. These peasants, farmers, and others are fond of working like this. The disease then spread to the deeper tissues and also forms sinus tracts leading to the skin surface. Enter into the skin, subcutaneous tissue, depth deeply into the muscles, compartment syndrome occurs, and then they reach to the bone. Mature lesions are characterized by the grainy discharge from these sinuses, and these discharges contain the fungal colonies and are infective to the other people. These discharges are definitely infective. The spread of the infection internally through blood or the lymph is uncommon. It is nearby, actually, diffusion through diffusion, they spread like this. Infections that produce a black discharge mainly spread subcutaneously in the red and the yellow varieties, deep-seated occurs early, infiltrating muscles and the bones but sparing the nerves and tendons. They do not involve the nerves through neuropathy or mononeuropathy, do not occur traumatic or non-traumatic type of nerves, not involve tendons are spared which are highly resistant to the invasion. This is very important. I will say that it is one of the most penetrating diseases in the world. They destroy the nerves and the tendons, no doubt. But this type of infection will not touch the nerves and the tendons. Remember these 2 points. Another terminology you are using are the botryomycosis, also known as bacterial pseudomycosis, which is a similar type of a clinical picture, and is caused by the Staphylococcus aureus gram-positive cocci. Other bacteria may also cause the botryomycosis. It is a pseudo type of mycosis. It is not the fungal one. It is bacterial one. It is other than the actinomyces of the bacteria. Actinomyces israeli, for example. This is also bacteria. So you should treat the bacterial infection rather than the parasitic infection or fungal infection. So that should be remembered. That this is differentially diagnosis should be done. It may be cellulitis, it may be carbuncle, it may be anything else which is streptococcus. Streptococcus is concerned, and actinomyces will cause the same picture. Sinuses are involved in this picture in a deep penetration, and but they can destroy the nerves and tendons. That is the difference between the two. They can destroy the nerves and the tendons, but the Eumycetoma will not touch the nerves and the tendons. This is a MADURA foot. Now you see that it is inside. There are the formation of the Eumycetomas. Inside there is a nodule here, and it is inside the bone, very near to the bone. Here it is the tibia, and very near to it there are a lot of granulomatous type of infection. This is present. Here this one. It is best demonstrated. This is the diagrammatic representation. You can demonstrate it exactly the same picture in MRI. The diagnosis is by biopsy visualizing the fungi under the microscope and culture, which show the characteristic fungal filaments and vesicles characterized by the fungi. Other tests include ELISA, immunodiffusion, PCR, DNA sequencing, so-called DNA barcoding. X-rays and ultrasonography may be carried out to assess the extent of the disease. X-ray findings are extremely variable. The disease is most often observed at an advanced stage that exhibits extensive destruction of all bones of the foot and causing the intermingle foot, or it is called the Charcot type of joints. Rarely a single lesion may be seen in the tibia, where the picture is very identical to what is called osteomyelitis. Cytology of the fine needle spirit or pus from the lesion can be taken out. Tissue biopsy may be undertaken sometime, and some publications have claimed a dot in a circle sign as a characteristic of the MRI feature. For this condition, this feature has been described on ultrasound also. If a good ultrasonographer is there, he can also demonstrate this type of a sign, that is dot in the circle sign. This is a plain X-ray MADURA. What you see here, this is again the thing I want to show here. That's the osteoporosis because of the painful condition, the bone or the foot is at the rest position. A lot of osteoporotic change here, but if I find these things very near to the bone, destruction of the bone, intermingle the bone, the joints are gone, and in this way, the Charcot joints type of joints occur here. But because they are sparing the nerves, that is why it is not called the Charcot joint occurs because of the impaired proprioception. Here is not the impaired proprioception, which is direct invasion and destruction of the joint. That is the difference between the two. So this picture is definitely a variable, and it may show the osteomyelitis of the bone, it may show the abscess formation, it may show the sinus formation. You can determine it. Now this is the dot in a circle sign. Remember this sign. This is the granuloma which is present here, and it is here. It is the dot in a circle sign. This is characteristically describing here. Also here. This is one dot in a circle sign in MRI or in ultrasonographic picture. Dot in a circle sign, you should remember it. Treatment is, if it is a fungal infection, itraconazole may be given up to 1 year when the grains are black. Black if it is, itraconazole. The third generation, which is posaconazole, is another option, and the varicoconazole can be used for infection caused by the fusiform. For the fusiform, it is more effective with the voriconazole. Otherwise, the itraconazole is a very good drug, but it is very costly. Now, ketoconazole has been used to treat the Eumycetoma, but it has the main side effects of the ketoconazole on the liver and on the kidneys. Actinomycetes usually respond well to the medical treatment, but acroatic infections are generally resistant and may require surgical interventions, debridement, etc., including salvage procedure as a bone resection or even the more radical amputation. Oral phosrabunoconazole is a new drug, much cheaper in itraconazole. An important factor is the Eumycetoma, mainly affect the young adults in poorer rural areas. A cheaper drug was found in 2003 in a phase 2 trial clinical to be safe, patient-friendly, and effective in treating the Eumycetoma. Because you have to give this drug for 1 year. Remember this, that is the cost effectiveness is important. The prevention is that no vaccine is available because there are multiple organisms, no one, not a single one. Simple hygienic precautions like wearing shoes or sandals while working in the fields and washing hands and the feet at regular intervals may help. The hygiene, taharat, barefoot, no barefoot. A lot of diseases can travel to the barefoot because you have to educate the people to avoid this type of infection. If it occurs, that is very, very, destructing type of a lesion. So please try to communicate to those people who are coming from rural area. They should not walk barefoot. They should wash hands and feet regular intervals. I hope that this small lecture will help you in understanding the MADURA foot. And I am sure that those who want to obtain knowledge, but nothing but the knowledge, it is very fruitful. Assalamu alaikum wa rahmatullah. Wa ma alayna illa